You're live, sir.
Take the load off.
Okay, well, Rodeo, thanks so very much for the invitation. So we set this up several months ago, but what I thought is maybe we'd bring a little pet therapy in. I know Cindy was real involved with animal rescue and stuff. So really the star of the day, I think, is the dogs. So can we just introduce the dogs one by one? Can we start, sir?
This is Thor. He's a therapy dog over at the West Bloomfield branch of Ford Hospital. He's 4.5 years old. He's been working there since he was a year old.
This is Trent, and he is 4.5 years old. He came from the rescue that Dr. Cindy Ray volunteered with, as do I. He volunteers not here at this big hospital. We're very impressed coming here. We volunteer twice a month on Sundays at Detroit Metro Airport. He has to go through security like all the other people. He's a real trooper that way. We also volunteer sometimes at Special Tree and nursing homes, but our primary place we go is Detroit Metro Airport, which is the Michigan Freedom Center, which is like a USO if you're not familiar with it, but it's all volunteer, and it's for not just active military, but retired military and their families.
This is Darby, he's a golden retriever. Darby is 11 years old. He's been working for 9 years, and we currently come to him for his visit, and we do two of the other Beaumont hospitals.
This is Fergie. She's 7 years old, and she's just been doing this since October. And we visit down at Henry Ford, the Wida.
And this is Odie. Odie is 9 years old. He's been doing this since he was 14 months old. He's my third therapy dog, and he is a season visitor. We go to mostly schools and do reading programs with children. Studies have proven that if children are afraid to read or not strong readers, when they read to dogs, they are successful because the dogs don't criticize them or correct them or anything, and so they feel much more comfortable, and it really helps kids learn how to read. That's one of the main things that we do, but we do go other places as well.
Great. Well, thanks. Well, I talked to Bruno a couple of days ago, and he thought this might be a good idea based on what this division has gone through. And then I called Ryan Schultz, who's head of volunteer services, and he said, yeah, I'll call. He says, I think I can get someone. And about a half an hour later, he says, I got 5 dogs coming. So thank you very much. So today what I'm going to do is just give an overview. I know we're rolling out the PERT team. I think Mike Eichenhorn talked to the fellows. And Sarah, are you going to do a few slides also? If it's you can or can't, tell me, and I'll know how much time to spend up here. Your choice.
The slides that I think the fellows went through them already with
Okay.
though.
Yeah, that's what I heard. So I stretched mine a little bit, if that's okay. All right, great. Let's make this very interactive. So big, small, tiny, and unprovoked PE is what we'll go through. Again, conversational will be better. Here's my potential conflicts of interest in case you don't know what these companies are. I've done consulting and used to do speaking for all of the DOAC manufacturers, some diagnostic. That is one of the reversal agents that's in production for DOAC. I'm not going to really talk about therapy so much today as I'm going to talk really about triaging, which is sort of germane with what the PERT team is working on. So big dogs, big PEs to start with. So let's make this case-based. A 65-year-old admitted to the ICU 3 days ago, COPD, pulse is now 95, systolic blood pressure is 110, respiratory rate 25, O2 sat 88, has some mental status changes. If you calculate the pulmonary embolism severity index score, and I'm a bigger fan of using actually the full score than I am the simplified form. There's a lot more elements, but it's easy to get to. I actually have figured out now. I have it on my phone. You can actually go to up to date. You can bookmark the page to up to date, and you can literally hit it. And so I hit one button, and the up to date PESI score comes up for me, so I can score that. I know Sarah's slides that she's been doing education with will have all of that, including the mortality risk. I've calculated for you the class 4, so this is a high-risk patient. They have a saddle embolism on the CAT scan, a right to left ventricular ratio of 1.1 on CAT scan. The troponins up, but the BNP is normal. The question is would you lyse this patient? Now, as a hospitalist here, I don't make that decision, but you all are making that decision in the ICU. So I guess yes, no, we'll do show of hands. You do have to play along. This is the interactive part besides petting the dogs. How many folks would lyse this patient? Systemic or catheter based. Let's go lyse. Okay. And wouldn't? The rest of you don't work in the ICU. Okay. All right. So, but because these are the questions that are now coming up. Okay. So, the 2012 American College of Cardiology guidelines recommended against. The 2016 guidelines, however, now are recommending if the patient deteriorates, will suggest systemic thrombolytics. Now they're saying systemic, and I know the field is moving also to a lot of catheter-based lysis. I'm not going to get into that. That's the technical stuff. I think if we can get the patients to the right level of care initially with the CT, the PERT team is then going to work on bringing folks together, because whether we give full dose, half dose systemic lytics, whether we give catheter directed, whether we use catheter directed with an ultrasound attached to the catheter or not, I think is evolving rapidly. I think the first thing that we need to get for is, do we have the patient in the right position, and are we bringing in the expertise to do that lytics if needed, and decide if we do lyse yes or no. And since about 70% of the room didn't raise their hand either way, maybe we have some learning to do. So this comes out of the European Society of Cardiology guidelines. This has sort of been the fundamental on what we've built the PERT team algorithm off of. And so this just shows the pathophysiology, right ventricular dilatation, increased myocardial oxygen demand, right ventricle doesn't pump to the left ventricle doesn't get filling hypotension. So we sort of have this death spiral, or what we will say, I'll have to be careful with this because we have lay folks in the room, but we all know that we will sometimes call this circling the drain. And this is a pathophysiology that goes into that. Here's, I think, if you sort it, for me at least, and when I teach hospitalists, if I'm going to use one slide to sort of base what we're going to do, I think this is it. And to get overly simplistic just as a starting point, I think that let's start up here in the red, high risk. Now, the European Society of Cardiology will do high, intermediate, low, and low. The U.S. guidelines tend to call this massive and this submassive. I think it doesn't matter. That's why I've said big, little, and tiny. But here, obviously, if we're in shock, that's a no-brainer. You need to move quickly, and we know whether that's lysis or sometimes when that's shock, that's actually ECMO in the ED, and then go to the operating room and crack the chest, depending on the patient. Virtually all of these patients, if they're in shock, it'd be very rare to have a low PESI or simplified PESI score and be in shock. So all these folks are going to be higher PESI scores. And then what they will typically have is signs of right ventricular dysfunction. We're going to talk in a minute on whether you do that with the CAT scan. Now, when I teach hospitalists, I'm much more in tune to say, look at the CAT scan, because you already have the CAT scan. And I know the PERT team and Mike Eichenhorn has sort of worked with radiology, and they're going to start giving us now that right to left ventricular ratio on all of the CAT scans. We did a little project with residents just a couple of months ago. I'm not sure why I had to review 1,000 PE reports. I thought that was working with the residents part of the plan, but anyway, so I personally read 1,000 PE reports. And we weren't collecting that data, but anecdotally, I got to tell you, I didn't see the ratio in probably more than 5-10% of the positive PE reports. So we're going to try to change that so you'll have that initially, because sometimes it might be until the morning until you get an echocardiogram. The literature suggests that actually doing an echocardiogram, a correct echocardiogram, can give you a little bit of better insight in what's going on with that right ventricular strain. But boy, if it's saying 1.2, 1.3, and certainly the cuts are either 0.9 or 1.0, you have that already. As soon as you know you have a PE, unless it was VQ'd, you know what that ratio is, and so hopefully we're going to have that readily available for it. I have called a lot of radiologists and asked them to relook at that. Yeah, Manny.
Now, does that index the positive pressure ventilation?
Pardon?
The ratio is that index the positive pressure ventilation with or without positive pressure ventilation?
Oh, this is mostly, my understanding is this is the diagnostic, not ventilated. I don't know about the patient on the ventilator. Yeah, I understand that will change that. My understanding is this is all not on a ventilator. Good question. And then cardiac biomarkers. If you got completely simplistic, just to get a starting point, I'm going to stress just a starting point. To me, it seems like this is an ICU, obviously. This one should be going home or at least go to the OBS unit because we can discharge these patients very early. Floor in ICU, maybe, as a starting point, just to sort of break this down, because I think it is important that we have the patient at the time of diagnosis in the right environment of care. So, here is also from the guidelines. The guidelines are about 80 pages long, so they have lots and lots of nice tables. Sorry, this is cut off a little bit. But what you can see, I think, here, what we're looking at is the negative predictive values are for mortality here. So echocardiogram, a little bit better than the CT. This CT is a cutoff of the ratio of 1.0. You'll get more sensitivity, so you'll improve your negative predictive value if you use a ratio of 0.9. Then you can see BMPs, and then troponins have mostly been the troponin T down here. And I'll show you, and this is what was used actually in the Pathos trial, which is the next study we're going to talk about. This is the largest to date trial of lytics in patients with intermediate risk. No one's doing trial and the patient was shock, okay? So this is where we need to make the discussion. So the question is fibrinolysis useful for intermediate risk PE? It's a randomized double-blind intention to treat analysis trial. Patients had to have PE, and here they were taking them out to 15 days. Of course, some of that is because we're trying to recruit to this trial to get enough of this. So this trial is applicable up to a clot within the last couple of weeks. And of course, we know, and you all see the consequences of that with the pulmonary hypertension. And some of the theory is take that patient that wasn't trying to die but had a clot last week so you could present the downstream effects of pulmonary hypertension. It's a bolus of systemic lysis, so this is not catheter-directed lysis. The comparison was placebo, so obviously blinded, and death or hemodynamic collapse within 7 days. So there's been some discussion around whether you should do death, but if you do the sample size calculations, and I've seen that written at least in one review paper, it gets ginormous for that if you're going to use death as your outcome, which is what we're really most fearful of. So hemodynamically collapse also, and then looking at major bleeding. If we look at the efficacy in the primary outcome, so this is death and hemodynamic collapse, we got a difference here of 0.02. This is a superiority p-value. That's a 3% difference. Number needed to treat is 33%. But if we look at the mortality, there's no difference in mortality. So really what this trial, my take home from this trial of about 1,000 patients is that IV bolus, full dose, systemic lysis, what it will do is it will decrease for every 33 people that I do, they won't have the hemodynamic collapse. Now the ACCP guidelines I showed you, what they said is they said consider this for patients that are deteriorating. So it's these 3% of patients extra that were deteriorating where sort of a lot of the action and post hoc analysis in the Pathos trial were. So that's where we are. Of course, there is a price to pay, and this is systemic, full dose lytics. So the most feared complication is highlighted in red here, is that it's the intracranial hemorrhage. And of course, the theories are either going to half dose, can we preserve efficacy and improve safety, or can we give even lower doses of that if we can drizzle it or ultrasound it into the clot with a catheter right up there in the embolus. So that is the theory. So this is the downside. What was really interesting is this was published in April of 14, and then just a couple of months later, actually, there was comments on the McMaster EBM site. Gord Guyot was part of this. Gord Guyot is up at McMaster. He is the person that coined the term evidence-based medicine. And what they did is that this is really how you want to do this. Publish in April. In June, you have the systematic review adding to this. I've highlighted the Pathos trial. You can see the numbers here. It dwarfs. There's more patients in the Pathos trial than all of the other intermediate risk PE lytic trials to date. Sam Goldhaber did the seminal paper in 1993 for us in the PERT team. And Sarah, if you want, Sam is coming and talking at our conference in 2 weeks in Dearborn. He's going to come in a night early. We're having a faculty dinner. I thought you, Mike, others that are interested, if you want, come to the faculty dinner. It's good to co-chair the meeting. I get to invite whoever I want to the faculty dinner, so you're invited if you want anybody else so we can have some conversation. But Sam has been doing this for decades. Sam is also on the committee that runs the PERT team. You know, they have a meeting in Boston every summer. I think they're going to have their fourth one this year. Okay, so here it is. Here we can see the diamonds. This is for mortality. So to me, the best way to say whether I have hemodynamic collapse, whether I have death from pulmonary embolism, where I died from bleeding in my brain, at the end of the day, you can count the caskets. So here is a way to do this. So in this systematic review now, intermediate risk PE, if we look at all-cause mortality, it was decreased significantly, so that diamond did not touch the line of unity. And the number needed to treat for every 65 patients suggested in this. However, we have to be careful, because some of this data is ancient, okay? But if we do that, then the number needed to treat is 65, but the number needed to harm for a major bleeding is only 18. So for every life you save, you're going to cause some morbidity in about 4 patients. So that's what your ratio is. And that's why I think it's not a slam dunk and why we're not taking all PEs immediately to lysis. Okay, so here's the small dog. This comes from this is the website from the Rescue League that Cindy was involved with. If you think the big dog and the small dog, I'm trying to see the correlation, everyone get a little smaller dog. Wait till you see the tiny slide. That's really cute. So that's coming up. So, okay, 31-year-old patient, acute symptomatic PE, secondary to oral contraceptives, no cancer, no heart or lung disease. Vitals are good. Would you treat this patient as an outpatient? Yes? When I say outpatient, since we're not doing that, we're not down in the emergency room, but if they come up to the pulmonary floor, would you send them home the next day, I guess is what I'm saying. Yes?
Yes.
No? Chickens. Okay, so, let me show you. So in 2012, the ACCP guidelines said early discharge. In 2016, they're suggesting home therapy. And there are a lot of case series, and reasonable case series, a couple hundred patients now, consecutive, well-done cohorts that have followed the patients prospectively for 3 months, and those mortality rates, those recurrence rates, those bleeding rates are pretty similar to what we would expect historically. What you would really like to do is you'd really like to see a randomized clinical trial, however, to say if this was safe. And I think it's safe is what we're really most worried about here. So the PESI score I've already talked about. There's lots of ways to do this. As I already said, I have mine fired up with UpToDate because that's something that everybody has, because we all have, at least faculty all have an iPhone from the hospital, so easy to set that up. Why I like the PESI more than the simplified PESI, and there's been 3-4 studies that have correlated the two of these, is because remember, this is a prognostic tool. So this is not a diagnostic tool. So I'm not talking about the Wells score that helps you decide what your pretest probability is. This is prognostic. what is the risk of death within 30 days. That's what this tool is doing. And it has been validated now 21 times. I challenge you to find a risk assessment model that has been validated 21 separate times. And here is the forest plot of those validations in this nice systematic review, now 5 years old. Arnaud Jeski in the group out of Geneva really put this together, and his group, and Jimez is also in that group. So the group out of Geneva has done most of this. But there have been others. You can see the forest plot. If we pool this all together, the mortality rate for low PESI score, class 1 or 2, is 1.6%. And we know for PE, that's what. Also remember, lots of folks with PE are going to have some cancer and stuff, even in the low-risk patients and some of those. This is all-cause mortality. This is not PE-related mortality, which is much harder to define. So, fortunately, we do have, similar name now, a randomized trial in Lancet from now almost 6 years ago. So this is not new information anymore. Can low-risk PE be treated without hospitalization? It's a randomized trial. It's acute PE with low class 1 or 2, and they use PESI score in the RCT, only RCT to date that I'm aware of. The intervention was outpatient. The comparison was inpatient. The outcomes are recurrence at 90 days, major bleeding at both 14 and 90 days, and all-cause mortality at 90 days. If we look at recurrence, this was set up to be a non-inferiority analysis, okay, just to say that treating wasn't worse than, outpatient wasn't worse than inpatient. There would be no pathophysiologic reason why you should expect superiority. So when you see the p-values, they are non-inferiority p-values. Recurrence, 1 in the outpatient, 0 in the inpatient. So whether you know stats or not, that seems kind of similar. Major bleeding, 3 and 1. And overall mortality, 1 and 1. So this is the study in Lancet that really showed us and was the underpinnings for the CHEST guidelines to say that outpatient therapy is reasonable. And I think what it is backed up with, if you will, real-world data on multiple cohorts from primarily Europe and from Canada to show that it's safe. The Mercury trial just completed enrollment. The Mercury trial is in patients with pulmonary embolism trying to treat outpatient with rivaroxaban. And so we expect to maybe see those results maybe at American Society of Hematology in December of this year. So there are 2 criteria. You can use the PESI, and it's really important to understand the difference between this because ED talks about this criteria, that it's a Hestia. I'm going to say Hestia criteria and PESI mortality prediction. They're 2 completely different things. The PESI will predict if the patient's going to die. The Hestia criteria, developed by the Dutch in a cohort, prospective cohort, so followed very closely. They did 3 months follow-up. Here were those results. And what you had is you couldn't have any of these. Hemodynamically unstable, DAW. Lytics, DAW. Active bleeding, DAW. But there's also some things in here. Is the medical situation okay? Is the patient pregnant? Some pragmatic things that we wouldn't think about sending those patients home. Here's the one that we might have trouble with down in my observation unit. That's requested a lot down there. But these are the criteria. So the Mercury study that I just said actually used the Hestia criteria. So we were really curious how well those align, because just because it says you got the home environment and you don't have another reason to be in the hospital doesn't necessarily score your mortality risk and vice versa. So intern, hospitalist, med student, faculty, research nurse, and myself. This was just accepted as a oral abstract at the International Society of Thrombosis and Hemostasis meeting. So I asked everyone who wanted to go, and I raised my hand first, so I get to go to Berlin, so that's fun. So this summer, 16.8% of our patients, we looked at 367 patients with confirmed PEs in our hospital during 2016. And we found that only 16% of them had either a low risk for mortality and didn't have any of the Hestia criteria. So only 1 in 7 if you wanted to do both. Nearly half of the patients was either had something that would exclude them or high mortality, so about half would absolutely need to be in the hospital. This is what got my attention and what I really wanted to investigate when we did this work. Of the patients that said they meet this criteria, about 1/10 of them had a high mortality prediction. And for me, I'm more worried about the mortality, because the rest of this stuff is just sort of common sense, regular doctoring stuff. So that's why, at least in my mind, what I do is I start with the PESI score first, look at the mortality, and then I go here next to see if it's reasonable that I can send the patient home. And once and I'm hoping by end of summer, after we roll out the red and yellow part of the PERT team, we can start to move towards sending patients to the OBS unit with where the Division of Hospital Medicine will take care of those patients, so we can not admit these folks and do that safely. Told you it was going to be cute. Okay, so the tiny clocks. 67-year-old male, URI symptoms, mild shortness of breath, returned from a 10-hour trip 4 days ago. Past medical history is negative. Pretest probability is low, but sorry, Manny, but this is probably the only time this would never happen, right? Where you get a CAT scan before you got a D-dimer in the ED. Okay, sorry, man. So, single subsegmental pulmonary embolism. PESI score is low. What would you do? Here, I'm going to sort of force you a little bit. How many folks would admit this patient because it's a PE, and most of you said that you would or didn't vote, and treat for 3 months? It is a pulmonary embolism. Anybody? Discharge home, treat as an outpatient for 3 months. Yeah? Okay, so still treat them because it is a PE and it is United States, and the Canadians don't have American lawyers. I agree. Okay? All right. D-dimer, lower extremity ultrasound. Someone, you get to pet the dogs extra if you say that. Hint, hint, hint. This is what the guidelines say to do. Still no one, okay? I gave you the answer. I gave you the answer. I'm petting the dogs extra because I knew the right answer. Okay.
Can't get them after 6 o'clock.
Right. So here it is. These are the 2012 guidelines. Okay. In patients with subsegmental and no proximal DVT, so they're hedging their bet a little bit. If it's low risk, consider clinical surveillance, i.e. not treat, and high risk, treat. So it's really interesting. There's no randomized trials. Cochrane just published, I think in January, the Cochrane review on this. Now, if you've ever read a full Cochrane review, sometimes it can be 200 pages long and all the tables. This is a one-page Cochrane review. That's where it says, there are no trials, we can't say. Done. It's a one-page Cochrane review. So there are no trials, as in Cochrane will scour the literature more than anyone else within the last 6 months. So,
Dr. Kaatz, what if there's 2 small subsegmental PE?
Well, let's go into that a little bit. So the answer is nobody knows. But here's what has started this. So this is really an interesting paper now in 2011. The theory, now when we went to, so the CAT scans used to do this, right? Hold your breath. Single head. I was around when we had single head. We thought, oh, that was really a great looking picture. And then they got faster and faster. I remember seeing a billboard one time that said 256 head CT, come to our ER. Okay, so as the cameras got better, we could see more. So what this is this is a time trend of, let's go where pulmonary embolism was in the primary position, so probably most accurate diagnosis. Here we're seeing just a little rise, not much before CTs are introduced. Once we get CT pulmonary angiography, it takes off. And I think you can keep seeing the diagnosis increase as the cameras get better and better and have more fidelity. However, here's the mortality. So there was a tiny drop during these years in mortality, probably better therapies, ICU care, etc. But it stayed fairly flat, with the argument from an epidemiologic standpoint that we're getting a lot more PEs, but we're not having any difference in mortality. Are these PEs really that important? So those are, and there's several other papers. I picked this one really because I think the graphics tell the story so nicely.
Doc, shouldn't it be logical that if we're now diagnosing a bunch of stuff we used to miss, we've increased our denominator, shouldn't the mortality go down?
Yeah, so that mortality is PE-related mortality.
No, that's what I'm saying though. So now, before we had only people, following your argument, we only had people with real PE,
Right.
and only a small subset of them are going to
Yeah.
die. We've increased the number of people, none of those people are going to
Right,
die.
right, so this should be a steeper
Should be
decline.
lower.
Yeah, I agree. So, but that's the argument,
Yeah, but this is persons per 100,000. So it's not mortality, like how many patients are dying out of that population. It's just
Oh, out of the whole.
I'm sorry, it's rate adjusted.
Thank you.
Thank you. Wish I would have answered that. Thank you very much for participating.
You get to take a dog home with them.
Yeah. You won the prize.
The muscular one.
So there are a lot of papers here. I've just picked two to make the other argument then, and these are really samples. So all of these patients in this cohort study have subsegmental PE, 300, a large cohort. They're all treated with an anticoagulant, okay, so it's not answering the question, should we not treat those? Of the 116 subsegmental and the 632 more proximal than a subsegmental branch, here's what their recurrence rates are. Now, these are low because everybody is anticoagulated, but these authors made the argument, really not a lot difference on the recurrence at least, whether they're subsegmental or whether they were proximal PEs. And then there were also a number of, and then since this was a cohort of possible PE patients, here is what the recurrence rates are if the patient did not have an initial PE, because just because you have the symptoms, some of those patients will come back and at 90 days follow-up, their COPD was first, but now they developed a PE, heart failure, et cetera, and here was the subsegmental. So showing that what you have is, the argument in this paper is subsegmentals recurred, and so they sort of acted the same as proximals. And what we had here is, and they acted different than patients that didn't have PEs, making the argument that maybe there is a recurrence rate and they are important. And then if we go back to the guidelines and look, and we have high risk for recurrence. So a lot of times when we find these incidental subsegmentals, they are in the lung cancer patient, the restaging, we're getting a CAT scan for following up oncologic disease. And so here is a review of cancer-associated incidental PEs. And what we see here is the patients that didn't get any treatment, here's their recurrence, suggesting that maybe, that's at 6 months, maybe at a 12% recurrence, maybe these are an important thing to treat. And here's what happened on whether they were treated with low molecular weight heparin, our standard, or a vitamin K antagonist. So the recurrence rates, tiny numbers, I'm sure if we put confidence intervals around those they would be wide. But a suggestion, and again, I picked out something that was sort of more graphic than anything else than the best methodologic study, just to make the argument. So I think the issue is we don't know. So let's move, that's my favorite picture that I saw.
I'm sorry, based on everything you showed us, sounds like there's plenty of argument to treat. So where did the guidelines come up with the idea that we shouldn't treat?
Well, that's really interesting, and I don't quite know, but the person that chaired those guidelines are going to be at our meeting in 2 weeks, and what I do at the end of our meeting is I put Well, I used to call it difficult questions, now I just call it pimp the panelist. And so I will ask Clive Kiernan that question, because I don't know. I'm going to see Clive in a couple of weeks. He's actually at AC Forum. I'm going to see him twice in the next couple of weeks. Yeah, Manny. But great question, and I don't know. I think it's just sort of some conjecture. Just if I may for just a minute. But what Mark Carrier out of Ottawa has written more on this than anybody else. We actually were able to get Mark to come to Dearborn in a couple of weeks. And Mark is doing a study. He's leading in Canada, France, and Switzerland. And what they're doing is they're doing a very careful, federally funded, prospective study of not treating low risk, if you will, subsegmentals. And they're going to follow that. And that's going to be our best information to date. And that's funded by the Canadian equivalent to the NIH. So it'll be done really well. But I think he's still, and that's up on clinicaltrials.gov, but I think he's a year or two away from having that data. So it's interesting. We actually looked at participating before I left, and then the Canadian government came back. Literally, swear again, they said, "No, we're not taking any American sites. We're afraid we're going to get sued." that was their equivalent to the, I think it's Canadian Heart Foundation and stuff, because we looked at the protocol a long time ago. Yeah, man.
One of my favorite stories is the reason why Chris Webber, he's a professional basketball player, is not in jail, is because the guy that was going to testify to the grand jury to say he took money in college came in with the PE and ER. He was screened, he was sent to the floor as F2, and he coded and died. And he actually, that's why Chris Webber's not in jail.
I just remember when he called a timeout and they didn't have any timeout left. That's the one that I remember. But I have a Spartan symbol on my jacket, so that's why I remember that one.
But the point is, in the interface of early PEs, when we see them in the ED setting, we're looking for hemodynamic derangements that predict hemodynamic compromise. So things like lactate, shock index, things that indicate what we'll call impaired oxygen delivery to tissues, which are more sensitive than, you know, so I'm wondering, why is there an absence of that kind of detail in these scores and what have you?
Yeah, so I don't know if that's, I don't know, okay? When I read through the ESC guidelines, which are now several years old, okay? It's fairly detailed, and you know, they're one of the better guidelines, so they do fairly good systematic reviews and stuff. My guess is there isn't as much about lactate and measures of oxygen delivery as there is about right ventricular infarct or failure, and so that's where most of the information is right now. Whether we could develop by incorporating those better risk scores, yeah. What I do like about PESI, however, because other risk scores prior to that were a lot more complex, and I think the reason that PESI worked is because you always have that information. You know, not sure everyone gets a lactate when they're worried about PE. And when we did our small review of that, I think of the 367 patients, there were maybe 2 that we couldn't retrospectively get a PESI score on, because it's built with elements that are just always collected and always documented.
Yeah, it's just to say that if a fellow gets a call from Sterling Heights, patient got a PE, should I admit discharge, lactate 7, conversations gone.
Well,
you're going to bring the patient in the hospital, so it's just that, you know, it's a test that's easily done, and I'm not saying it's the end all, but it's just to say that that's kind of how we screen a lot of these patients. So.
Yeah, I agree, and I think this as a starting point, and so Sarah, you've rolled this out to lots and lots of group, but it's a starting point. You still got to look at the whole page, you know, you got to pull out your stethoscope, you got to be at the bedside and do this, etc. But I'll tell you, in internal medicine, there's a lot of, I don't know where they should go, and should I keep them or send them or call them the pulmonary fellows a lot, probably a bit unnecessary sometimes.
And I think the other thing that's come up is really this is the goal behind the PERT team is to streamline the process and to make sure that we are looking at these intermediate high risk patients. Identifying them as intermediate high risk doesn't mean that they will all get some sort of lytic therapy, but I think it's just having those discussions with the interested parties and coming to some form of conclusion for that patient, but at least not missing the patients that would benefit from advanced intervention.
But I agree. You give me that score and a lactate of 7, they ain't going home. So, I'm not real smart with ED, but I'm smart enough to know that. So,
Dr. Kaatz,
yes.
going back to the subsegmental PE,
Uh-huh.
I'm having a hard time reconciling that between the low risk and high risk, excluding patients who are on, who have cancer. So,
Right. So when you read the fine print, which is about a paragraph in the guidelines, it mostly says, oh, no. So I'm paraphrasing,
so
but
what would you do? Would you
I treat most of my subsegmental PEs. The only subsegment, because most of the time, at least in my experience that I'm seeing these, is the patient gets cancer. Why else are they getting a CAT scan? If it's picked up serendipitously, if the radiologist CAT scans the belly and they say, oops, and I think I see a tiny little one as I cut up above the diaphragms and it's there, maybe not that one, but at least in my experience, a lot of these that I see are in the face of cancer, and that seems like a pretty high risk. Not only that, particularly if they have cancer in the lung then, because now the lung's already compromised, so they have less reserve to handle another small PE.
So for patients with no cancer, was there any guidance on, do you follow them back with another scan, maybe?
It doesn't say that. The point is we don't know. And so I treat most of my patients. However, if I have a patient that's just got horrific bleeding risk, and they have a subsegmental, I'm also not putting a filter in them. I'm having a lot of conversation with who's ever going to follow that patient and a lot of education with the patient, but I'm not reaching for a filter because they had a PE and I can't anticoagulate them. That's probably the scenario where I would think about not doing that. But that Venn diagram gets to not have a lot of overlap.
Okay. Can you consider putting them on aspirin instead if you don't want to anticoagulate them?
Yeah, so the question is aspirin. So we know aspirin works a little bit to prevent recurrence after venous thromboembolic disease, but that's after a course of usual anticoagulation. So the Aspire and the Warfasa trials both told us that, okay? Although I think with the Einstein Choice trial that just came out a couple of weeks ago in New England now. In fact, I don't know if it's in print yet. I think it's just early release. It was presented at ACC. That showed that at least rivaroxaban just was far superior to aspirin, and it had the same bleeding rate as aspirin. So now I'm not sure that I'm a fan of aspirin as of about 3 weeks ago anymore, because I have a drug that works way better and is as safe. So, and low dose apixaban also, from a couple of years ago in Amplify Extension trial, also in the New England, showed that low dose apixaban had similar major bleed rates to placebo, but was better. So I'm not sure aspirin holds up. But I never think about using aspirin in acute treatment. I think about it only used to think about it only in patients for long-term prevention. And it has a efficacy of about a relative risk reduction of 33% compared to placebo. Great question. All right, that one we did. So unprovoked, and I will hustle this up. So let me just walk through this. And let me give you the concepts and show you the trial. To me, in my mind, and I agree with the ACCP, the answer on how long to treat a pulmonary embolism, and I get at least half the folks will say 6 months. And 6 months for VTE treatment is never the answer. It's 3 months or it's indefinite. Those are the points. And that's what the guidelines say. And here's the 3-month reference. So This really goes back to the seminal paper by Trevor Bagland out of the UK, showing all the patients are anticoagulated here with DVT and PE. If it was surgical provoked, there were no recurrences. If it was completely idiopathic or non-provoked, here's the recurrence rates. These are the soft ones. Airplane flights, estrogen therapy, ICU stay, and then total hospital stay of 7 days for heart failure, etc. That's in between. If we look at the paper from Giancarlo Agnelli back in 2003 in the Annals, what you can see, this isn't very good graphics back then. All the patients are treated for their pulmonary embolism here, and then one group is randomized to stop. Here's the recurrence rate. The other group continues to this point and then stop, and there's the recurrence rate. The interpretation of the paper was there's no difference. That was then later modified from now what we say is it just delays recurrence. It doesn't prevent recurrence. So whether you treat for 3 months, 6 months, a year, when you stop, the recurrence starts. So it doesn't make sense to go longer than 3 months. The decision is 3 months or indefinite. Same thing was seen 2 years earlier in DVT with the same looking curves by the same group. Everyone says when I hear about a non-provoked PE, they say, well, what lab data? I want to do a hypercoagulable workup. So they want to do factor V ligand, prothrombin gene mutation, or, et cetera, et cetera. So if you want to do a genetic test, okay, see if the patient has a Y chromosome. Okay, that's the genetic test that you want to do, okay? You could do an exam also, but, okay, because here it is, the Dodd study, we participated in this study with the research group up on K15, came out a couple of years ago, now led by Clive Kiernan, who has chaired the last 3 iterations of the CHEST guidelines. What we did in this study is we had 410 prospective cohorts, so this is real prospective cohort. We called the patients, they came back in, we saw them, we followed them up, our follow-up was 98%. Younger patients. At the end of standard treatment that was clinically decided, we did a D-dimer. If the D-dimer was positive at that time, they stayed on anticoagulant. If the D-dimer was negative, we stopped. Then we brought the patients back a month later. We did another D-dimer. If the D-dimer was positive, they went back on. The first patient I saw and I went into, the patient was really upset. I made the co-PIs do the rest of those, okay? So, because the patients did not want to go back on anticoagulation. What we found is patients that had an estrogen related, it was still controversial whether this was provoking or not. This paper put that to rest. No recurrences in women that were on estrogen therapy that had already been treated for 3 or more months here. Okay, so estrogen is provoked. Treat it just like if the patient had an open cholecystectomy, if their leg was in a cast. If the patients had a positive D-dimer, then they went back on anticoagulation or stayed on anticoagulation. We know even with anticoagulation get some recurrences, but this is 3-year recurrence, about 3-4%, so the anticoagulants work. In women that were not on estrogen therapy and had negative D-dimers, here's their recurrence rate. In men, the same thing. These were their recurrence rates. Christensen, back 12 years ago, had the first epidemiologic study, I think it was in Circulation, showing this phenomenon of men recur about twice the rate of women. We have multiple studies now. This is one of the better studies with robust data. Your male patients will recur twice as much as your female patients do. So what I do now that I'm not an ambulatory doc anymore in a hospital, I still have that conversation with my non-provoked patients with PE that are men. I tell them you're probably going to do that. It goes in the discharge summary, and I call and educate the primary care doctor that's going to make that decision so they don't stop at 3 months. Here we look at a study from Jim Duquettis. Red is men, women is without estrogens, blue is with estrogens, so it follows the same pattern. These are just positive D-dimers, these are negative D-dimers. What you'll find in the Annals paper that I just showed is men, even with a negative D-dimer, were 8% per year. Let me say that again, 8% per year. That crosses everybody's threshold in a low and a reasonable bleeding risk patient to continue. There's the symposium comment? Yeah.
I actually need to go back to
That one?
So, my understanding of reading this is that the positive if the patient has a positive D-dimer,
We treated them. In this study,
for how much longer? Do you just do a month and then recheck it?
no, these were all non-provoked. We kept them on indefinite.
Okay.
Because that was the theory at the time, was what to do.
Okay, so a positive D-dimer is basically your marker that there's some reason that you're developing it, it's much higher than the standard individual.
Yep, and it came from this paper that had already been out at the time that the study was designed. Dotted lines are positive D-dimer, bottom lines are negative D-dimer, the same groups.
Okay.
So we already knew that when this protocol was put together. Okay, what the news out of this paper is if we treated all the men with positive D-dimers, okay, so we can't answer that epidemiologically because it had already been answered. The question was, what about the men without? Because a lot of people were risk stratifying them. And our point is, men without, here's your recurrence rate, 21% at 3 years. When you do the Kaplan-Meier analysis, it turns out to be 8% per year. Did that answer?
It did, thank you.
Okay, so big clots. We got a PERT team now. Think about that, and even if they're not going right to lysis out of the ED, I think where we place that patient to watch for rescue therapy is important. We have some tools now to predict mortality. Small clots can probably be treated outpatient or at least go to the observation unit or be discharged the next day. What you have to do is, and I agree not doing this in the ED because you got to line up, you know, which medication and the case managers and pre-authorization and yada, yada, yada. So parking them not in the ER makes sense, but I'm not sure they need to be on the floor. Subsegmental, no one knows. Personally, I treat most of those. And unprovoked men, I just start out of the gate and tell them that they're going to need indefinite. Women, I lean towards, if it's not hormone related, I lean towards treating long term. But in my higher bleeding risk patients, I'll risk stratify at the end of 3 months with a D-dimer.